talk about the topical issue in the society. And today we want to tilt our attention to children. Children, when it comes to how to take care of them, the emergencies, the first aid, to look at their health, and how important this response that we give to them is when it comes to taking care of them. We have two women in the house who are medical doctors who have been on the field and on that aspect of taking care of children for so many years. They'll be telling us what we should do as women or as families when it comes to emergency responses. We have Dr. Nafisa Shobanke, a senior registrar, pediatrician, FMC. Abeokuta. You're welcome to the program.
Thank you, ma'am.
Thank you for coming. And also Dr. Marufa Togundeyi, the Chief Consultant, Pediatrician, FMC. Abeokuta is also here on the program. You're welcome to the program, ma'am.
Thank you, ma'am.
Thank you for coming and talking about our children.
Yes, sir. Thank you for coming. Glad to have you, ma'am.
Thank you, ma'am.
Okay, so on the emergencies, to attending to children and first aid, I'd love to find out, this issue with a lot of Nigerian parents in the way they respond to emergencies in children. Have there been maybe situations where we've had maybe a lot of parents, not react, speedily to emergencies in their children? And what are the issues exactly that probably you've experienced as a pediatrician?
Thank you very much. Good morning, everybody. Let's first start with the definition of an emergency.
Okay.
What is an emergency?
Okay.
Emergency is a sudden problem or a life-threatening condition that, if care is not taken, can lead to the loss of life or permanent damage to that individual. Most of the time, most parents believe that children are small adults. Children are not small adults. And emergencies do occur in children because of the peculiarity of their age.
Sure.
One, they are highly adventurous. Two, they are unable to explain the symptoms. Three, because of the interaction with the environment, they are unable to identify dangers. That is, okay, this thing is dangerous, this is not dangerous. Then four, there are some things, especially in our environment, that we believe that, no, it's a small child. The child is going to overcome it. So, what are some of these things and what are the commonalities? Let's start with the simple one. Fever illness.
Okay.
When the child is having fever, it's just a small fever. Please, we're going to school. We've experienced this everything.
Wow.
The child, they will wake up in the morning. They will touch the body. They don't have thermometer. Most mothers in this environment, they don't have thermometer. And if a parent do have any child that's less than 5 years, you must have a thermometer as part of your package in the house.
Oh, wow.
So just, the body is hot. I've given you paracetamol. I've given you some other drugs that we can't mention so that we don't emphasize for them.
Okay.
They're going to school. The next thing we call them in school, this child is convulsing. What we call febrile convulsion. At times, the child might be complaining of headache. It's because you played too much yesterday. Children do have hypertension. Hypertensive encephalopathy.
Really?
Yes.
Hypertension?
Yes.
Wow. Okay.
There are so many that my colleague will also talk about some of them. A child who is having diarrhea, who is vomiting, and you are sending the child to school. The body size of children is very small. And when they lose any little quantity of water, they are going to lose a larger proportion of the body fluid, because most of the time about 60% of our body is made up of water.
Yeah.
So they lose that one, the child becomes dehydrated, maybe in shock. A child is packing that cold urine and the parents ignore it. The next thing, the child has destroy the red blood cells. In severe anemia, consulting, and so many other things.
Okay. All right, Dr. Nafisa, let's talk about what we should have in our first aid box. I know that most homes and some schools have, some do not have, but I know most homes we do not have first aid kit for our children. So if you want to have the first aid kit at home or in school, what should be the composition of that? What medicine, what tools, and what are the things that are essential to tackle emergency when it comes?
Okay, thank you very much for that question. So I would like to start with where my superior colleague started from. She mentioned issues of diarrhea. So when you have a child that is having diarrhea, so a component of a first aid kit should be things that you can easily use. So things that within your reach when emergency situation arises. For example, you have a child that is having diarrhea, you don't have what we call oral rehydration therapy at home. So this should be handy because in children we call it water of life for them. So and you should be you yourself you should have knowledge on in situations where these things should be prepared and should be given to the child. So you should know about how this should be constituted, what volume should give to the child. That's the one. She mentioned issues of fever. So things that can easily identify, because she said it earlier that children like this can have what we call fever conversion when you don't deal with the fever. So things like paracetamol and ibuprofen for you to resolve fever. Then you should have a technique in which you can decide to spray a sponge. But however, if you've done this and this doesn't resolve, you know you have to present to the hospital for further management. A child has a cause, things like bandages, antiseptic solutions, methylated spray, things you use for clinic when they develop minor injuries at home. These are the things that should be part of your first aid box. And also, there are also other things that you need to what's it called, have in big box. Like she mentioned earlier, the thermometer is also a very vital what's it called, because some people will just tell you, oh, this child is having fever. Did you actually know how bad this fever is? Because if you know how bad this is, when you know that, oh, this is kind of fever like that, you measure the temperature, the thermometer is telling you 40 degrees. That kind of child, you want to wait at home, you know you have to rush to the hospital. So, and when you are aware of these danger signs, you have your first aid kit to which you want to tackle these emergencies at home. You've done what you can, and you know this is not resolved, then you know you have to present to the hospital.
So what are the common mistakes that parents or guidance do while handling emergencies? You know that when it comes, sometimes it comes so suddenly, and sometimes you don't even know what to do. And when you get to the doctor, they'll tell you, why did you do this? You should have done that. So what are the common mistakes?
One of the commonest mistakes that we're still making in our assignment is when the child is convulsing.
Okay.
When the child is convulsing, though with health education, the frequency at which some of these things are arising are reducing, but we are still saying that a child is convulsing. They said, no, the child is doing giving, you know, in our local parlance, that somebody should hold the child down. And in holding the child down, the child can break the bones. They said, go and bring salt, go and bring pepper, onion, spoon, cow's urine. Those could cause more damage. They are not treating the problem, they are causing more damage. I've seen a child that they said, go and put onion. The child lost both eyes. Became blind. The other thing we were serving like cutting onions. We know what could happen. Putting pepper in the eyes of the child, or putting spoon. There are still, so many parents are still doing that. They don't want the child to clench the teeth. No, clenching the teeth is not the management for the convulsion. If the child is having fever at that point in time, get a tepid water. The way I usually describe it to most mothers is that, like you want to drink a tea in the morning, a cup of tea in the morning that is warm, that is not going to burn you, but it's not cold. That's the kind of water we want. Try to bathe the child with it so that it brings the temperature down. If you have paracetamol at that point in time, give the child the paracetamol and take the child to the nearest hospital. Nobody should hold the child down. Nobody should put the leg of the child in fire. You see them already. Oh dear. They put the leg inside fire. The child now comes to the bone. You now treat the primary cause of the convulsion. You are now dealing with bone injury.
So with all these issues surrounding the way parents actually attend to their children during emergency, is there a reorientation program or something that doctors could do or actually do to be able to educate the parents? Maybe just the way we gather pregnant women together and we talk about pregnancy and child care and all that. Is there any program at all for parents to be able to educate them and teach them how to, take charge during emergencies
For example, when they come to our own outpatient department, these are some of the health talk that we do almost all the time. I know that most of the time the challenges is that when parents come to the hospital, they are only looking at their time. I want to be in the market. I want to be there at the office. But if it's an older person, they are ready to wait for hours. You know that we have the belief that it's a small child. So it shouldn't take long. It shouldn't take long. They need a small child. The problem should be small. So children are not small adults. They are individual on their own. So we do that. Radio program, television program, when we have the opportunity like this, we do it. And in our department, any mother that comes is part of the management plan. We let you know that okay, this is what they are managing the child for. This is the cause of this problem. These are the things that you can do subsequently to prevent or minimize. And if the child should have any problem, go to the nearest hospital. Maybe because of the stress everybody is going through in the country. For mothers, the information, they are unable to assimilate it at that point in time. It is understandable, and that's why when we now ask them, come back for follow-up, which is one of the challenges we still have. Don't you come back? We've seen a child like 2-3 weeks ago, who we managed 2 years ago, and supposed to come back. We never see them again until when they get the child almost dying. That we are even contemplating this time let's go to ICU and all the rest. And we are now, and luckily enough, when the 2 years ago, it was our team the nurse, he said that, I said, no, bring out your card. This is the date. You know, the night I went to my grandfather's place, I went to I traveled, but if it is an adult, they are likely going to come. I think we still need more education, more orientation, and all the rest. It's getting better, but we can still do. Okay, now let's talk about what you should look at for immediately you have your child. A lot of people will tell you that when you have your child and they are checked, the first immunization is given, then the child should go home and you start rearing the child. Do you need to come back for any checkup? I hear that you must know the blood group of your child, but for some parents, they don't care. They don't want to know except there is an emergency and they need to know. So what should be the step of parents or schools or maybe guardian when you put to bed? What are the steps of health care that you should give to your children?
Okay, thank you for that question. For a child that you just give birth to, there are steps you need to follow to ensure that the child is growing well, the child is fine, and there are no other complications that could arise after giving the birth. For example, in the first 7 days of life, you have to be able to show that this child is not jaundice and the likes, because you know all the complications that can follow after jaundice. And these consequences are very grave in the first 7 days of life. A child that is a 10 baby, and in the first 10 days of life, in a child that is a preterm. So you have to take care of that. Especially if you have a previous history, you have to be on top of telling your doctors that my child do have jaundice, and you don't want a devastating injury to be developing. So that's that. Then after these days, it has to do with nutrition, which are the feeding, which we encourage mothers to do exclusive breastfeeding and the likes. It has to do with feeding to ensure that the baby is growing optimally. Then immunization. Immunization clinics where you do your immunization. And immunization is not a one-time thing. They say there is a schedule that will follow when you are at birth, 6, 10, 14, 9 months, or we get to 5 years, and even older children, because we have human papillomavirus vaccine and the likes now. So what do we do? Because in an ideal setting where things are working properly, a child that is taking immunization regularly, this should be the first thing that will be the first message that alert the clinician that something is wrong with this baby. For example, you go for immunization and febrile, they refer you, go and see the doctor, this child is having fever. Then, for example, when you go to immunization, so there is this graph that will plot for the height and the weight. So a weight is the first pointer when a child is not going well, because there is this curve that they plot, the line graph. There's this graph that says that this child is not going well, you need to go back to see the doctor. So they will refer you. So a normal parent that is making sure that this child is well immunized, this child goes to the clinic, they are the first detector that, oh, there is a problem with this child, and they refer the child to the appropriate physician to see the child. For example, now for a child that is not going well, in our setting, most times it's in nutrition, because we see children, they are malnourished and the like. So we do the general rehabilitation for them. And most times this malnutrition, there is always most times an accompanying infection, we treat the infection, and the child goes there. And most importantly, the parents to recognize danger signs. When they see these danger signs, they present to the hospital on time.
So do we look at the body parts too? I hear that some children go blind when they grow. There are some illnesses that will happen to them, and they will go blind. And they will tell you, if you have checked the eye, you should have detected. So at what point of life should their body parts be checked?
At every consult with the clinician, we do what we call the thorough examination. But for some people, for the blindness that they talk about, if you have a child that is preterm, that's why we ask them, they prescribe us, and we ask us to come back to hospital. That's what we call retinopathy of prematurity. And this retinopathy of prematurity is because this child is preterm, not well developed. And once they are delivered, they will definitely have some issues. And because of the treatment they are going to receive and all the rest, and because of the risk that they are going to deliver. So even after discharge, maybe 2 weeks, 3 weeks, we always schedule them, the ophthalmologist to see them, the nutritionist to see them. If they need to be seen by the endocrinologist, the cardiologist, depending on if there's any abnormality that was detected in the first year. And they are usually follow up for the first 2 years of life. Any child that is at birth has been delivered who has jaundice or has anemia, infection, or some other problem, we also follow them up for the first 2 years of life. Is this child developing at the rate the child is supposed to develop? There's an expected age for the child to be able to control. There's an age that when I smile to the child should be able to smile back to me. There's an age that is okay, if I drop something, the child should be able to turn and be functional. Yes. Or I hold something, the child should be able to not to take it from me. So those are some of the things we ask the mother to observe. We have a child that is 4 months, 5 months, and the child is still unable to hold the neck. There's a problem. Or people are crying, or maybe it's making noise, the child is where it's not trying to follow face, it's not smiling. We have to ask the ophthalmologist, please check this child.
It's autistic.
We don't make diagnosis of autism before the age of 3 to 4 years. Because some children, they are growing normally, but at a slower rate.
So it's still within
but it's still within what is expected. That bracket. So we don't just label them as this child is autistic
because they are not growing at your own pace.
It's like to be in a class. Somebody will be soft and somebody will be tense.
Even somebody will be fast.
And that's what especially when the child is like a third or fourth child, you are trying to compare the way that it is doing with your fourth child and the second child.
Or a child that is not doing
the same way.
And one of the problems we are having also again in our environment is what we call language confusion. To our children. Don't speak vernacular. Hope you understand.
That one.
So the child gets confused.
And affects the brain.
So when affects the brain, it's okay. So the child now says that it's okay. If I speak, maybe I want to speak Igbo, and my mother said don't speak vernacular, you want me to speak English. I said, listen, the English you are speaking is not correct. You're shouting down. The child is just looking at you and won't say anything.
And you'll be worried as a parent.
Yes, because they are able to child to different languages at the same time. Maybe the father is Yoruba, the mother is Igbo, someone speak English. So you're exposing the child to three different languages. Yes. So the child just said, I'm supposed to delay for the child. It's because I'm talking to you now.
Oh, wow.
And the child just, not that the child is smooth, she doesn't understand perfectly well what you're saying.
Wow.
But because the way the child wants to express himself or herself, we do not allow that child
It's been shut down.
to express himself.
But how about children that probably they mix up English language? You understand? They mix up, but then you're trying to correct them. Is it that we shouldn't, feel that impulse to correct them all the time?
No,
or just allow them?
Development is age-based.
Okay.
A child that is less than 2 years, the child is trying to get his or her own identity.
Sure.
So in school, the child is mixing with so many people. There are so many languages has been taught to, and that's why some mother would say, when the child gets to school, the teacher do not complain. Because the child is at a free environment.
Okay.
If like the child can speak English, teaching English, can speak Yoruba the way he can mix that with a with whatever. It's meant understand what he's saying and he's learning. But at home now we are confusing the child
And restricting
the child.
Wow.
So we start, if the child gets to school, is this child interaction with others? Is this child interaction with grandparents, maybe elders, neighbors, and all the rest? And you see when the parents are not there, the child will be at his element.
Wow.
Free and doing.
Okay, before we go, now let's talk about them. Let's come back to this child emergency of first aid. At what point should a parent be afraid or take it serious that this illness or this mild fever is something that I should be worried about? At what point? Now that I do not have thermometer to check, I do not know if the skin color, I have heard doctors talk about skin color.
Yes.
If the skin color is changing or not, and I'm still managing at home, at what point should I rush to the clinic?
You know that as mothers, most of the time, or as parents, we only have what is called instinct. When they are healed, we know. But we are just trying to wish it away. I always tell people, you have a 2-year-old child that's very active. You have a 2-year-old child in this studio. We can't sit down like this. If the child doesn't have any problem, you ask a 2-year-old child to sit down, to be still. Maybe in the first 2-3 minutes, you will still. The next thing, the child
Is everywhere.
is everywhere. A child that is feeding very well is now refusing the feed. I don't like people saying, use the hand to touch. Get thermometer. Because it depends on the weather. And that's why, the Yoruba balance that could the bonus sister. So the body still appear cold. Yes, because if my hand is very cold, and then if the child is hot, when I touch it will still appear
Quite cold.
It's cold. And that child is having fever. But you have the thermometer. The thermometer is not expensive. We all buy credit monthly data. So thermometer is not expensive. Get a digital thermometer. The moment that temperature is getting to 38, you need to go out. But before you leave the house, step a sponge. This paracetamol. Because it can be air infection, it can be throat infection. Take to the nearest hospital so that the child will be examined.
Okay.
A child that is feeding very well and suddenly is unable to feed very well, the child may have what we call tonsillitis. And tonsillitis in children could be dangerous because there's pus collection in the tonsils and it can block the airway. And they say that the child was playing and stopped breathing suddenly.
Oh, wow. Okay, on this matter of emergencies, I'm sure there must have been situations where culture and religion, must have, halted some emergency situation. Like, for example, we've heard of some religion, they don't allow blood transfusion. So has there been any experience whereby this issue of either culture or religion had come into play in children emergencies?
Thank you, Ma, for that question. It's one of the challenges that we face.
Yes.
It's one of the challenges that we face. You know, the culture. You know, at times the mother knew that this child is sick.
Yes.
But I want to take permission from my husband or my
Pastor.
religious leader. But with health education across the religious outreach, with health situations, the child will need blood, and because of the religious inclination of the parents, they will bluntly refuse. And if they refuse, what we need to do at that point in time, if the child actually needs it, we may have to call in those who call justice of peace.
All right, thank you so much.
Thank you very much, ma'am.
Permit us, because the issue of children is something very, very important that we must take care of. And I want to thank you so much, Dr. Marufa today, for coming on the program, and also Dr. Nafisa Shubanke for your time on
Thank you very much.
We need to go. Out of the studio now. It is time for us to wrap up. Next week, Monday, promises to be another interesting one. It will be bringing to you Ladies Rendezvous program, and on this show we'll be doing around the world and also talk about something topical in the society. We'll see you again next Monday, God willing. Have a great day ahead of you.
Thank you. You may come.